We're going to use presentations and have a chance to be community. Thanks again. Can everyone hear okay? On the chat, can you everything that you somewhere? Let me ask you. Our October and November meeting. If you haven't had a chance to look them over, noted now relationship 3 minutes and go back to the beginning. All in favor of approving the minutes indicate by saying thank you. Before we continue on, something else that we have to do in our table. I think most of and wanted to take a moment to acknowledge his contribution to the city, contribution to the community. It was completely unexpected and incredibly. And as you all have so, in honor and all of the need for but also one of his really had idea that people action, and he really, really looked up to his voice. And as if you all remember, that are really memories, Bob brought him to us, and he shared his experiences and the amazing work that they did at the and it was well beyond just Bob. And I'm going to end with this. I think Kathy Sullivan at the King County Prevention Coalition and Bob actually did like a podcast to try to keep us connected. That's cool. And like it was so like he just did it, and he just knew how to keep the community together and really make up. So I want to just offer some, just some memories of Bob, and I know that you want to celebrate it. So thank you. We do have a full agenda for usual. We are going to go through the presentation, and then and we have updated on
First, I know that the Zoom folks are having trouble hearing. Is this better? Is this better? Can you hear now? Is it easier to hear?
It is better, but it's still echoing.
Further away than
Well, let's move it so it echoes a little bit less.
yeah, we could carry that around with you as a.
And now, how is it? Is it a little bit better?
Yeah,
really
much better.
much better. Okay, that's good. For everybody who doesn't know, I'm Marty Rosenberg. I'm the Director of Policy Planning and Research here at the Executive Office of Health and Human Services. Welcome to all the new folks who have not been here before. We see a lot of new faces in our audience. We welcome you. I'm going to give an update on our fiscal year 24 projects. We have a few that are new to be announced today. And I want to also remind you about an upcoming deadline with the Rhode Island Foundation. So as a part of work that was requested in FY23, procured into FY24, we have 3 new outreach programs with a focus on BIPOC communities. We're very excited. I think last time we talked about Project Where We Renew, and they had finished their procurement, and we could talk about them in the last meeting. And they are sustaining harm reduction and overdose outreach in Kennedy Plaza, expanding day and night outreach programs, expanding their court support program, and providing anti-stigma trainings. That is not a good sound. Hold on, I'm gonna wait and. All right. We can also announce today that Amos House is going to be using strategic canvassing to provide naloxone and training, as well as support and recovery information in neighborhoods with predominantly BIPOC residents. So all of these activities are aimed to reduce stigma and establish community-based medical care on site and connect people to community-based medical care on site at Amos House. Horizon Health is conducting Rafa healing circle groups within BIPOC communities, specifically engaging people who identify as Black African-American women with a focus on Providence, Pawtucket, Central Falls, and Woonsocket. And so they're going to be connected through partnerships made with local stakeholders such as church groups, recovery houses, and community mental health providers. So these 3 programs are brand new. requested by you committee members and put into procurement through the purchasing process. Thanks to our partners at the Department of Health for all of their work on this, and those programs have already started. As a reminder, there are 3 different projects that are going to be, that are in a grant process right now at the Rhode Island Foundation. Our partnership with the Rhode Island Foundation has been extremely helpful. Last year, you know that we worked with them on both the nonprofit capacity building work and the community-based prevention, youth prevention work. This year, we have 3 projects that you asked us to do and that we felt were best carried out in a grant program with the foundation. The first is trauma supports for first responders that it absolutely includes peer recovery specialists. And you can go onto the Rhode Island Foundation website, and when you get the annual report, is it in the annual report? No. On the Rhode Island Foundation website, you will find where that grant deadline is. And we also sent it out recently. That's what we did. We sent it out in the notice of this meeting, and we sent it to our entire listserv. So the first is the trauma supports for first responders. The second is family support. So organizations that work with family members of folks who have experienced an overdose and recovered, people who have passed away from overdoses, any kind of family supports. This is something that you all thought was very important and couldn't quite get it right with the purchasing process, and the Rhode Island Foundation made sense to allow this for very, it could be small organizations that very local organizations that can apply, and hopefully it's easy for them to do through the Rhode Island Foundation. And the final one that is open right now for the Rhode Island Foundation is for re-entry support. So people coming out of prison, people who are unhoused, who need supports. It's like a basic needs, but it's much more specific than that. And it's kind of like recovery supports, but again, more specific for re-entry. So I encourage you to look for that last email that we sent out about this meeting, and the link to the application is there. The deadline is February 12th. And I also want to call your attention to something in your packet, which we're pretty pleased with, the opioid settlement annual report. This is the report that we're required to do for the legislature and the governor. And we were happy to do it because you will see all of the details on all of the procurements. Again, we try and update this on a regular basis. This is our annual report. It has all of the funding information for FY23, and it talks about allocations as well, and a lot of detail on procurement. So happy reading, and of course, as always, we're happy to answer any questions that you might have here or later.
Any questions for Marty? Thank you, Marty. And as I mentioned, we have slighted Kathy in the past, and so we bumped her up so as not to slight her again today. And I'll just, before she starts, I'll just say this. The Governor's Overdose Task Force is, as we all know, very complimentary to this Opioid Settlement Advisory Committee. To the extent that you are able to attend the Governor's Overdose Task Force meetings, that's hard to say quickly, please do. Sometimes there are redundancies in content on the agenda, but quite often there are not. And increasingly what we want to do is optimize the time spent in each setting so that we don't repeat presentations here that were just offered, a month prior, or we offered a month later, for instance, at the Governor's Overdose Task Force. What we will try to do though is to make it as easy as possible to share relevant information between the groups, whether it's snippets of recordings, because the Governor's Overdose Task Force meetings are very well attended and are always recorded. Or it may be materials from a presentation that we then also share from the Governor's Overdose Task Force that we share here, or vice versa. So just know that we are thoughtful about that and trying to make the best use of everyone's time. So when I ask and invite you to attend as often as you can the Governor's Overdose Task Force meeting, it's not a requirement, it's an invitation. Please know that we are inviting you with the intention of not wasting your time and having duplicate information shared, but rather hopefully enhancing and further information that would inform the work here at OSAC. Kathy, please.
Hi, everybody. I am loud, but I'm gonna use a microphone and I'm gonna follow directions and use it. So thank you for that, Carrie. So just to like give a little bit more information of like, we really want to make sure that the information here is shared to the task force, that the task force information is shared here. The task force is the largest community convening meeting in the state on overdose prevention. It was actually developed by the community for the community with state leadership, obviously, and state representation for the administration and the facilitation of the meeting. So a lot of the presentations, I'm repeating what Carrie said, that are, you know, some of the presentations, the one you're gonna see today, I actually was in the, you know, shout out to Woonsocket. I always like to give a shout out to Woonsocket. I was actually part of the health equity zones in Woonsocket, and in some of the presentations you're gonna see today are actually the code projects, which have actually started years ago, and they're gonna give you a kind of a presentation of that. So for the last task force, and that's why I'm talking about that, what we did was we actually highlighted some of the work that's happening in our high burden regions. Because we didn't want to duplicate today's presentation here. And we focused on Providence and Woonsocket, and some of the more overarching work that they're doing in harm reduction work, as well as recovery supports. And you know, that mobile outreach that they're really doing out on the ground. As well as some of the amazing programs that we may not always hear about from our partners at Project Weber New, as well as Community Care Alliance in Woonsocket. So that's what our last task force was. It was very community-led meeting. And any recordings, we're gonna put it in the chat, and if anybody needs to get would like access to the Prevent Overdose RI website, one of our advisory committee members is part of that. You can go to the Prevent Overdose RI website and you can see any of those presentations. I think it goes all the way back to, is it all the way back to 2015? So you can look back at any of the older presentations. The other thing that I want to try to offer to all of you is to look at the Prevent Overdose RI, because there's some amazing work groups. We actually have our community co-chair from the Racial Equity Work Group here, state co-chair, and Dennis actually is our community co-chair of the Racial Equity Work Group. Sorry, I gotta give Monica a shout out while she's sitting in the back there. So, you know, we really try to wanna work together, and we really want to make sure that you all have access to all the work that's going on, because there are actually, I think 10 work groups. I keep saying 11, and Carol corrected me. I should know this. But there are actually 10 working groups of the task force where they kind of dig deeper into some of that information. And then I'm going to move on to next month's agenda for the task force. We are going to be focusing on some data. There was a deeper dive for the 2022 fatal overdose data, specifically on our Hispanic and Latino community. And that is going to be followed by the overdose fatality review, specifically on the same population, or the same folks. I don't really like the word population, so I'm going to correct myself. And we're also going to have an introduction to a subgroup that has been formed. One of our members here is actually part of that. There's going to be a short presentation, just an introduction to this subgroup's formation, how it formed, what they're doing, and how they're going to connect to the Racial Equity Work Group, and followed by some guest speakers that we're still kind of working out some of that. So if you are interested in looking at some of the fatal overdose data from 2022, we did see an increase, 50% increase in our Latino community fatal overdoses. So we're going to do a deeper dive, and we're going to be strategic, and we're going to look at some of the programs that are out there and introduce some new partners into our task force. We're also working on making sure that this task force is translated. So that's what we're going to be doing in February, which will be on Valentine's Day. Unfortunately, the topic isn't the best for Valentine's Day, but it will be on Valentine's Day, starting at 11:30. I should know these things, right? So if you have any questions, you can see me at the end of the meeting. Thank you.
Thank you, Kathy. Any questions for Kathy? Excellent. We also had to punt Tamara and from our December, I'm losing track of time, November meeting. Thank you, Gianna. Because we didn't meet in December. Who was going to provide an update on the evaluation framework that EOHHS is pursuing. And so we're excited to have her here virtually to present. We're wishing her well because she got the COVID cooties. And so she's keeping her distance from us, but she is well enough to present, and we're thankful for that. But just as a reminder, the evaluation framework that she's going to be sharing with you is not the evaluation purely for OSAC invested project programs. Because OSAC dollars, as you know, are operating with stewardship dollars, with Medicaid dollars, with other resources. And so, and it would be nonsensical to have an evaluation framework for OSAC separate from these other funding streams. So it is an evaluation framework for this opioid work. It is an evaluation framework for EOHHS, which is reflected in the approach to evaluation that multiple agencies are contributing to. Trying to think of anything else I want to say in preparation. I don't think there's anything else I want to say in preparation. So, Tamara, can you unmute and just confirm?
Yep, can you hear me? Maybe, okay.
I can hear you on Zoom, Tamara.
Okay, I'm going, Carrie, I'm sorry, I can't hear you, but I think if you can hear me, then I'm just going to go forward. So thank you for that. I apologize, I can't be there in person. And again, I just am going to talk about the approach, specifically evaluation of the strategic plan, Carrie, that you had mentioned. Again, it's in its whole. And then hopefully get some feedback as to what information particularly the committee would like to know, and then the important piece and how you would use it. So if you can hit next, please. Primary focus of the evaluation, again, I'm talking about the framework itself, is for the impact and effectiveness of the strategic plan, the roadmap, which I'm sure most of you have heard that being mentioned. Again, the plan itself, it's collective. So you see the word, the collective impact. And what that means, it takes many different projects and initiatives from different funding sources, as Carrie also had mentioned. And we piece that back, excuse me, into different priorities. And then we measure, are we making progress on our one common goal? So you see here, the common agenda. And we're working to have shared measurements and standardizing these common measures from all of these different pieces. So as you can imagine, we're kind of working on piecing some puzzle pieces back together, all of the different programs and initiatives back into the strategic plan to measure and ensure that we're working towards this common agenda. If you can hit next. And so when I say, yep, next, please. When we say, actually, I just need to note that this is outdated information that was from November. So I just want to acknowledge that. But when I talk about the common agenda, just want to establish and level set that we do have this common goal. And obviously all of these pieces are fitting together to work to reduce the overdose fatalities. This is a goal that has been approved and endorsed. Everyone is really working towards. Although nothing really occurs in a vacuum, this is the primary measure that all of these pieces are contributing to. I also want to lift up, obviously, this is the common agenda, but there are other existing primary measures that are being tracked by the data teams, and I'm going to leave that to Christina Schultz, my data partner, is there too. So if there's anything that I miss, the team can talk about that as well. So those are the primary, and then again, there are secondary measures. If you can hit next, please. So again, most of you have seen this before, especially if you've been to the task force. This is the graphic of the strategic plan, kind of use the logic. It's really important when we're thinking about the evaluation that we're using this. You can see it towards the center, those four multicolored, the rim. Those are the primary priorities that have been in existence, everything for many years. They have funded initiatives and projects that have been existing, but I do want to lift up that it is important to note the evaluation is really leaning into the principles of the roadmap. So thinking about the lens and using on the outer rims there, you see governance, data, racial equity, and social determinants of health. So not only looking at like the programmatic level like reports, which are in existence, and you're going to hear about one later, programs are measuring and their outcomes, but the evaluation as a whole, thinking about the everything pieced together, the different priorities, and then looking at everything with the lens there that you can see depicted in this graphic. Excuse me, if you can hit next. Excuse me. So there's a multitude of different approaches. If anybody knows anything about like evaluation, there's all different kinds. I just want to lift up a couple that we know that we are going to look at. So outcomes based evaluation, there are again existing initiatives. So we'll be able to share and look at that, what have been measured and captured through data, what changes have happened. And then we're also going to be using some process evaluation approaches about like how well are the programs working and the processes are working. And then most importantly, very importantly, as we're talking about a collaborative approach, incorporating all of the different groups of individuals who are going to use this information to inform what is important for us to understand to make improvements. So if you can hit next. And with that, an important piece, when we say participatory evaluation, there are groups of folks that are being engaged to inform this work. So you can see here, I'm not going to run through every single piece of information, but you can see here this committee, the OSAC committee, it's important. We understand what information you all need and how are you going to use it, all the way through program level organizations that are the ones that are doing this work. And so to what degree are their programs impacting their target populations and tying that back in. So that's really an important piece that we're thinking about the folks that are most impacted, as well as doing the work, all the way up to folks that are, making the decision and figuring out what information. So there's lots of pieces that are going to inform this evaluation. Can hit next, please. So today, I know we have a guest speaker to talk about one particular program and the outcomes that they have achieved, but I just want to lift up one particular priority to give you as an example of what the evaluation approach is about, very briefly. So harm reduction. Harm reduction, you've heard a lot about. Harm reduction and rescue are one of the priorities you saw in the roadmap logic model. So I've been working trying to collect and piece information together thus far from what we understand. There's 5 initiatives that have been funded through the settlement, 3 of which are launching. Again, can't say enough that there are different programs at different stages, right? So there are some that are new, some have been in existence. So there's different pieces of information that we're trying to put together. There are at least 11 organizations that are doing the work and performing work. So that's what you see here. So if you look at the leftmost column, again, when I'm talking about that kind of comprehensive evaluation, the leftmost column are the particular strategies in the pillar. And then in the center column, we're looking at the funded programs. There's also some that are not funded and how they fit into each strategy. Again, all different kind of ways they're collecting information and also different stages of the program. In the rightmost part, again, we're looking at what data is being collected. There's lots of data. Every program is collecting their own reporting and outcomes, but they might have their own reporting system at their respective agency or organization. But this really is an important piece of the evaluation, is collecting and putting back, again, all of these pieces of data from a program level, like that very granular level, and piecing that back in to our strategy. So this is kind of a very, an example of a data metric that we're collecting and piecing back together. So if you can hit next, think about the data. And then we also have to think about, we're collecting all of the pieces of information around like funding sources. Much like data, we're tracking the funding sources of each particular initiative to understand on the stage of where it's at, if it's been existing, where the data and reporting is being collected. And then we're also thinking about for sustainability purposes, because I know that's also something that has been mentioned and wanting to lift up, like for the future of the initiatives and strategies as well. So if we can go to the next slide. What does this mean for all of you, and what have we been doing? So I've kind of alluded to this. I'm tracking down, compiling all of the pieces of information because there's a lot of initiatives and programs and things that are happening at their own respective agencies. So we're trying to piece everything together. So from the program descriptions, reporting all the pieces of information, the amounts of funding for each program, we're organizing them, and we're backing it back into the overall strategic plan. The information, processes, standardizing measures, sharing reports, we're still working on kind of the processes of collecting the information back into this. So it is a process. I'm also in the phase of getting feedback. So hopefully we get some feedback today around from stakeholders that are helping to inform the evaluation. We are in the process of finalizing a programmatic dashboard, and what that means, Christina Schultz over at UHHS is helping to create this. Again, a lot of this is dependent upon the program level data and information. We are also, for those contracts maybe that are at the programs that are contracted through EOHHS, we might be in different stages. So I just want to acknowledge that those are being considered and incorporating into the dashboard. But it might be from a programmatic like milestone stage, because we're not quite ready to start collecting outputs. So here I do want to lift up also that we're in the process of finalizing scope of work in an evaluation team with an academic institution, which will allow us to have a lot more information and bandwidth to complete the full evaluation. So in order to also know if our strategies, if they're working, we have to confirm and confirm these logic models when we're talking about the strategies. So we're working on finalizing those, which then incorporate standardizing measures. And that's when we'll know if these strategies are working or not. And so what will you have? Again, a public dashboard, we'll be able to see, know that we're working on an outward facing dashboard. I don't know when I'm done speaking if Brandon wants to share anything about that. And then you'll have a plan, the comprehensive evaluation plan, and you'll have regular updates. And then long-term, when I'm talking about kind of those target indicators to measure against for each pillar, you will have those as well. So very soon, programmatic dashboard with the reports, and then long-term, we're looking at kind of the overall measures for each pillar. So I have a question for the group. I don't know if you give feedback, maybe if you have questions too, but I'm really interested, and it's important about any specific information that could better inform your decision making. I can also share my email if you kind of need to process or have been thinking about something. So I have those questions, and then I do just want to share that if Christina or Kathy, if there's anything that I have missed to add here.
Let me just invite Christina, did you want to add anything? That moment where I was so- Let me invite you to use a microphone. Thank you, Rachel. And it may be off, you may have to turn it on. I think it's on.
You might want to stand up twice, Chris. Click it twice. Stand up.
Yeah, okay, here we are. At the moment, not too much information, still working on the programmatic dashboard. We do have a couple of, levels of data governance that we have to go through for that. But it is a work in progress. Yeah, if anybody has any data questions, I'm happy to answer.
Thank you, Dr. Chan. And because you got the shout out, Brandon, Dr. Marshall, did you want to add anything about the data dashboard?
Yeah, so as many of you know, our team manages preventoverdoseri.org, which is now under a contract with UHHS. So we're working to develop and tackling the issue of transparency. So trying to make all of this incredible information that we get as committee members accessible to the Rhode Island public and presented on preventoverdoseri.org. So we're in the early stages of that process. We're working on identifying how to coalesce all this information, focus now on where the money is, where it's going, how can people apply for funding opportunities, making that information as accessible as possible. And then over time, we'll work to add more of the evaluative components that Tamara is talking about. So we're actively working on that. Not quite ready to share anything, but as soon as we are, we can report back on our progress.
And because it's just a perfect segue, if I can just tangent for one moment.
Sure.
Marty, do you want to give an update on information about funding?
So we are working on the best way to provide the information on funding opportunities. And I think the one easy-ish way to do it is next time when we meet, we will create we will bring up the purchasing website and show you where it is. We may also be able to do a video. I'm thinking maybe there are videos on the purchasing website, but you need to know where the purchasing website is and how to get to them and how to find the videos. So I'm still working with purchasing to figure out the best ways to make that information public. But I wanted to let you know that we are working on it, and that if the simplest thing for me to tell you right now is that if you Google Ocean State Procures, that gets you to the purchasing part of the website. And really there are a lot of guides. You could look for the guides for registering. You have to register, and then when you register, you can sign up to be alerted when various RFPs come out that are of interest to you or that meet what your organization does. There's a help desk, so you can Ocean State Procures help desk, and you can get help in registering, which then opens up those doors for getting those emails. And then there are videos, there are guides. So if you poke around a little bit on Ocean State Procures, you can find it. But we are working on the best way to make that information even more accessible to you. And we'll be working, through the work that Kathy's doing with Brown on how to put that on the Corey website.
Thank you, Marty. Thank you, Brandon. So back to Tamara's, presentation and questions. Thank you, Dr. Chan. What questions do you have about the evaluation framework as it's been presented? What else would you want? Because ultimately the goal is to get evaluation information to the OSAC in advance of making decisions about funding for future years. So Adi and then Dr. Chan, she had her hand up first, Dr. Chan. What questions or comments do you have?
So, is this good? Okay. So one very Luddite question for Marty, is there a reason why you couldn't just put like a link or links on the OSAC website directly to the relevant procurements? Or
we are told by purchasing that purchasing is the one that need to put that out into the community. So we give them emails and they send emails to interested parties, like our interested parties list. That's how that happens. It is what we are told,
I mean,
has to
it's
happen.
public information, so if it's public to one, it's public to all. And I guess I don't really understand that answer. So I'm just going to throw it out there that if it is a public procurement that is available through that, sorry, I just blanked on.
Ocean State Procures.
On Ocean State Procures website, I don't know why it could not be. The information still resides there, but it's just your link to the particular procurements that are relevant to our work.
We can bring it back to them and have that conversation, yes.
Thanks, Marty. And then with respect to the, valuation, I understand this in some ways in advance, but I hope that part of the evaluation process would be surveys that, so not, I saw something about like feedback sessions, which is fine, but I think what would be helpful is to get surveys that have some objective criteria in there, like how many, individuals were, received services, or how many individual visits, and then satisfaction sort of surveys for the individuals who receive visits. And I imagine these are all probably pretty standard and frequently utilized by agencies that receive whether state or federal grants. So I'm just raising that as a question.
Wonderful. Yes, thank you. And thank you, Tamara, so much for putting all this together. So I have a couple just highline top level comments that I think would be helpful, at least for me, and I'd be curious what the group thinks. I think, we've sort of agreed upon addressing fatal overdoses, which I think we all agree is important. It should sort of be the top level goal. I mean, I'd love to see a couple other top level goals as well, that sort of relate to things like prevention and treatment and harm reduction. And I'm not sure, I'll come defer to you, Dr. Marshall, because I know that data and I hear yours sort of strong too, but thinking about things like overall overdoses or overdoses admitted to like the ED or EMS, I think it's important too, as we think about like healthcare utilization in our EDs. I think overall overdoses would give us a sense of, first off, how often overdoses in general are occurring, and then how often they're kind of utilizing our healthcare system. And then other sort of highline sort of data points as well, things potentially, I know some of this is on prevent overdose RI, but having it presented either quarterly or at least a couple times a year, things like buprenorphine prescribing, maybe methadone dispensing, syringe distribution, number of needles exchanged, Narcan, naloxone distribution, maybe even things like Hep C, HIV. So sort of maybe not the high level of reducing fatalities, which of course is the goal, but some of these other sort of high level data points that we all want to achieve to get to reductions in fatal overdoses. And I think we want to be a little bit careful about not getting too much into the weeds, because I think there's endless data points. I think we need to see and decide sort of what's important, including some of the, I think, as we move on, some of the ground level data. But I think we sort of want to have a picture of sort of top line goals that we want to achieve and to see those pretty, routinely, to see if we're making dents in that, to see if all the money. And then I think just on that, too, it'd be interesting to sort of stratify based on all these categories we have, right? Prevention, treatment, harm reduction, recovery, and to look at, have some markers, maybe a top level goal for each, to see if we're sort of achieving where we want. And the final point I'll make too is just to be cognizant of the rural urban, I think, divide. I think that we're rightfully so sort of focusing on the urban hotspots. But I also want to be sensitive that when you look across the state and certainly across the US, like the rural communities are often left out. And so I think we talk about communities and directing resources to different parts of the state, making sure we keep our eye on different cities and towns and also our rural communities as well, to make sure that they at least have access to some of these resources that we're building up in terms of our harder hit communities as well.
Thank you, Dr. Chan. I hear you asking for a dashboard that would be presented regularly periodically, we figure out what the right periodicity, is that the word, is. That would include some of those key indicators to let us know if we're moving in the right direction to achieve our top line goal of reducing fatality. And I think that's a very reasonable request and something we would all love to see. And with acknowledging all the limitations of data and how frequently things are updated and, data sources are updated, some measures we may present 2-3 quarters in a row and not see any change purely because of the frequency that the data is available to be updated. We can list all the caveats, but a dashboard would be helpful both for the OSAT and I would imagine for the governor's overdose task force as well.
So just to make a quick comment, so in March, we are going to be presenting at the task force the naloxone data. And like I said, we're gonna be presenting the fatal overdose data in our overdose fatality review next month. And then the next month, we'll do a presentation on some data from prevention. Then the next month, we'll do some prevention, some information on recovery. But what I did hear you say, and what we are actually working on, and we didn't want to get into all the details of this, is that we are looking at all the pillars and we're working with Prevent Overdose RI. We're working with our interagencies. This is like from a perspective of EOHHS, our respective state agencies, as well as making sure that we bring the community voice into all of this. And and as far as the surveys, you're absolutely right. It is super important that we make sure that we're getting the community voice in those surveys, right? So that we are expanding this as far a reach as we possibly can within reason. But to what you said, yes, we are working on actually having target goals for the pillars. We're determining that by doing the inventory. So what Tamara was just presenting is really the environmental scan and kind of where we are right now and what our timeline is for that public dashboard. But I do think that one of the things that I was saying earlier is it really is information that is available. It's even on Prevent Overdose RI now. It needs to be updated and we're working on that. So just to kind of answer some of those questions about some of those points. Thank you.
Yeah, so this conversation makes me go back to the thought on one of the core principles about the settlement and the stewardship fund was to supplement and not replace state, local, or federal funds coming into this program. So when we talk about tracking, is there a way, and I'm not sure if it's OSAC, EOHHS, or some other entity that should track and make sure there's not some slippage by the traditional funders for these programs, that that funding is stable and doesn't slip into or misunderstand that we are supposed to be supplemental. So if we can track those other budgets somewhere and make sure that they are complying and understand that we are one of our core principles and the stewardship fund is to supplement and not replace.
That could be, I mean, I'm giving work to other people, but that would be a great thing to add to our dashboard. That would be one that would be updated more like on an annual basis, just because of when funds are worth, but very worthwhile to track.
That is the plan, by the way. We're hoping to do that. That is part of the plan is not just, we know that settlement will go down. We know that it's amazing and thank you, we're grateful, especially me, because I'm directly impacted by it. So I can't be happy enough for it. But we also know that a lot of these programs were funded previously, or they have expansions of the programs or whatever from federal funding, and other funding sources, philanthropies, donations and all of those things. So we really want to capture everything. And that's why one of the slides that Tamara presented, it showed the funding and it kind of tried to show that grading that is happening with a lot of the funds that we have. And also to make sure that we're looking at the stuff that is solely funded by other sources that we may not see here, so that we can see, because this is all about the continuum of care. It's not done in a vacuum. It can't be done in a vacuum. This is an epidemic. So thanks.
Any final comments from the committee? Aditi?
Very, very quick. So I completely agree with Dr. Chan, as usual, and Senator Miller regarding the sort of need for this regular updated data points and dashboard in a way that's easily accessible to all of us. One other idea to include in there, if possible, is tracking the treatment beds and what percentage of those treatment beds are occupied and or waiting lists. So I think we just ought to know how many treatment beds we have for SUV throughout the state, across different providers. And so that we can better assess the need. Thank you.
Good suggestion. Okay. Thank you, everyone. Tamara, did you get some good feedback to give you some direction moving
Yes.
forward?
Yep. Yes. Thank you all very much for your time and feedback. And I know if there's any thoughts, everyone has my email or Kathy's. But I appreciate the feedback and know that a lot of these things are in the works as well. So thank you.
Thank you, Tamara. Okay, our next presentation will be delivered by Lauren. Where's Lauren?
She's on this one.
Oh, she's on the Zoom. By Lauren Conkey from the Department of Health, and I think possibly other colleagues may join in. But Lauren will lead and she will let us know who is presenting on the community overdose engagement project. And so Lauren, same thing, I will advance slides for you, but I will ask you to unmute and take it away.
Great, thank you so much. I hope you all can hear me. Thank you all for your time today. My name is Lauren Conkey. I'm with the Drug Overdose Prevention Program at RIDO. I'm joined by my colleagues in Woonsocket, and I want to give most of the time to them to talk to you about their specific project. But first, I would just like to orient you all to what community overdose engagement, or what we call CODE, is. There's a lot to cover, so I'll just jump right in if you don't mind advancing the slide. Oh, sorry, one more. Thanks. All right, so community overdose engagement, or CODE, started with a call to action. In 2017, then Governor Raimondo and the Department of Health challenged all 39 municipalities to create comprehensive overdose prevention plans that aligned with the state strategic plan. The goal was to help communities build capacity to respond to local overdose crisis, and also to enable community-driven decisions. Towns who created a plan were awarded $5,000. We offered a second round of this project in 2018, this time offering grants of up to $10,000 for communities that implemented at least one strategy of their plan. And 35 out of 39 municipalities now have created an overdose response plan through this project. Next slide. So mini grants are great. They allow the state to get money out really quickly. However, they do limit a community's capacity to effectively respond to the epidemic. So in 2019, our program received new funding from the Centers for Disease Control and Prevention that enabled us to expand CODE, offering a larger amount of funding for communities with a high burden of overdose to implement multi-year community-driven projects. Over the past few years, we've been very fortunate to be able to leverage additional funding streams to expand the program, such as the SOAR grant from BHDDH, and as well as some McKinsey and settlement dollars. You can see the three communities we funded projects in here and the timeline. Next slide. So because these are community-driven projects, each CODE looks a little different, and you'll hear more about the work in Woonsocket specifically in a moment. However, they're all comprised of the same 6 basic components. First, a backbone agency who serves as a fiscal sponsor and coordinator of the work. There's a needs assessment that was conducted based on both surveillance data that was provided by RIDO, as well as surveys and interviews and talking with individuals who live in that community. A diverse community collaborative made up of partners to drive the work. An action plan that was based on the most pressing needs that was identified in that needs assessment and is carried out by members of the collaborative. Communities who participated in the initiative also received comprehensive, up-to-date state and municipal level surveillance data by RIDO. And then they were required to conduct ongoing evaluation to track progress over time. And then RIDO as well in the back end was evaluating the pilot project to figure out what lessons we could learn from it. Next slide. So our CODE communities began implementing their projects in early 2020, right before the pandemic hit, which, as you can imagine, led to a slew of unanticipated challenges. And as with a lot of community-based public health work, it's hard to draw direct correlations between these programs and overdose rates, particularly given how complicated and ever-evolving the overdose crisis is. However, as I mentioned, we've worked extensively with each CODE community to evaluate their projects and highlight some key successes and lessons learned from the pilot. If you're interested in learning more about the work in any of our communities, we've created these code at a glance reports for each project, and we're in the process of publishing them on RIDO's website, hopefully within the next week or so. But for now, I'm going to hand it over to my friends in Woonsocket, and they can talk to you specifically about what code looked like in their community and share some important lessons learned. Next slide.
Okay, I think that's passing to me. My name's Susan Jacobson, and I am the Senior Director for Health Equity Initiatives at Thundermist. Thundermist is the backbone organization for the Health Equity Zone in Woonsocket, and the Health Equity Zone is a collaborative that uses collective impact to accomplish population level health equity goals. So next slide. And this is a group presentation. So just to kind of give you a little background on the Woonsocket Health Equity Zone, there are several priorities, and one of them is overdose prevention and recovery. And really, Woonsocket has been disproportionately burdened with overdose fatalities ever since the state has been collecting that data, and with the highest rate of fatalities in 2022. Our goals in the overdose prevention and recovery work group are aligned with the governor's task force goals. We rolled out our first strategic plan in 2015, concurrent with the governor's task force plan. And our overarching goal is to save lives and make treatment and recovery available on demand and in real time. Next slide. Okay, so what we're going to go over, and we have several folks talking about their piece of the puzzle in this work, but the overall Woonsocket Code project model will overview of the work and then lessons learned. Next slide. Okay, next slide. Okay, so this graphic is a demonstration of my advanced graphic design skills. So Thundermist as the backbone provides, as Lauren said, fiscal support as well as administrative support, including grant writing, reporting, etc. And so in that context, I worked with the committee and with our steering committee to develop this strategy around the code project, the level 3 code project that we launched in 2020. And we really thought about it, an overarching concept and groundedness in prevention. And we'll hear next from Lisa Carcefera, the director of the Prevention Coalition and chair of this committee, around the public awareness campaign that the Prevention Coalition led for the Health Equity Zone. Rescue and recovery. And so the foundation of recovery, and working with the Serenity Center that is operated by Community Care Alliance, and building capacity within that peer recovery resource, and developing an online app during COVID, because many of our plans to build workforce in person were really interrupted by COVID. So the rescue strategy in the middle, this is, a couple lines of our extensive action plan, but they were really important. And how can we engage the hospital, Landmark Hospital, around what I think Jonathan Goyer and the governor's task force has called that window of willingness. So if someone has experienced an overdose, or they are at higher risk of an overdose, and they are at the emergency department in Landmark, how can we respond in a way that makes recovery supports, treatment, and rescue resources available right there and then? And so this project funded embedding a certified peer recovery specialist in the emergency department, and then working with partners at Parent Support Network, Discovery House, Sojourner, Thundermist, and Serenity to coordinate those pathways and transitions of care. Next slide. So since maybe 2017, the Woonsocket has really relied on data, including geomapping. This map is developed by the Department of Health epidemiologists. Lauren Conkey referred to the data-driven work of these code projects. And so particularly around rescue and deployment of naloxone and other harm reduction materials, our outreach teams connected to the Health Equity Zone really focus on where are these hotspots, as well as when these hotspots fall, for example, in Thunder Mist's parking lot, or at right behind Community Care Alliance, et cetera. How can we as partner organizations respond directly when that hotspot is adjacent to us? Next slide. Oh, the next slide, I'm going to pass it over to my colleague, Lisa Carcefaro, who, as I said, is the chair of the Overdose Prevention and Recovery Work Group.
Thank you, Susan. Good afternoon, everyone. Yes, I am Lisa Carcefaro, and I've been really honored to partner with the Woonsocket Has to chair the Overdose Prevention and Recovery Work Group, which is comprised of dedicated individuals from our partner organizations within Woonsocket, also throughout the state, that are focused on overdose prevention, substance use treatment, recovery, and harm reduction. We have anywhere from 12 to 18 individuals that attend in any month. So for the Code 3, one of the project activities was the media development. So as Lauren already mentioned, it began in 2020 when we were all shut down in COVID world, and we began this particular campaign development during the summer of COVID. It was convened quickly because we had a great group of individuals to bring together. We got a designer in place, but of course, everything went virtual. So there was the challenge of pivoting at that point with Zoom and screen sharing and trying to do the brainstorming and feedback and all the decision making via Zoom. But there was consistency in attendance, and we really did make it work. We had some great individuals. We came together, created a number of creatives, many ideas and voices. Bit of a delay. Unfortunately, our designer had some catastrophic losses that year due to COVID and other reasons, but he was steadfast in his commitment to helping us create the best campaign as we could. We spoke about the narrowing of focus. We came to two different areas of focus. One was the polysubstances, contaminants, and fentanyl, and the other was an anti-stigma campaign. In the end, we decided on focusing on an anti-stigma campaign. And so we began with the full group, and then we ended up kind of bringing it to a subcommittee level, working on the verbiage, language. And we had one committee member that agreed to be or volunteered for the photo. And if you would just switch to the next screen. This is Jess Jones, an incredible individual who was part of the photo shoot and the creative development. The focus was on understanding stigma and being sensitive to those around us, family, friends, and coworkers that we meet each day, moving them from judgment to understanding and acceptance. And the One Woonsocket was really an important kind of tagline for all of us. Those that work in Woonsocket know how important it is for the organizations to really stick together on areas where we can it really is about collective impact. So this final creative is what we landed with. We placed it on an outdoor billboard that had 23 to 30,000 views each month. It was in print in the Valley Breeze, online through online newspapers, social media, and distributed through community partners. We did receive anecdotal feedback. We have 2 local radio stations that are very active. For those that may tune in, sometimes it's not always positive, but feedback was both positive and challenging. And I believe it's the challenging feedback, or what people might call negative, are the ones that really call to action and make us discuss the issue further, bring it to awareness. If people are talking about it at the local coffee shop, where they weren't during COVID, but that's a win, really, to bring out the awareness. So this was our campaign, and that's how it was launched. If you could go back to the previous slide, and we thank Jess for being our model here. The next is the data sharing, and Susan alluded to it. The heat maps, they were vitally important to this work group, especially. It really, during some of the highest years of overdose in Woonsocket, the heat maps offered that place-based data, and allowed us to make a quick response to the need for changes, or due to the uptick in overdose, allowed us to come up with timelines, allowed us to have detailed discussions and mobilization. So we were able to pivot and then outreach on those hot spots. And at that time, the code allowed for some purchasing of intranasal Narcan, which was quite expensive and cost prohibitive at the time. And it wasn't always as readily available as we see it now, but it allowed us to really focus our energies on those hot spots. And again, at that time, we also recognized the need for streamlined information to distribute. So during those difficult times in COVID, when everybody was shut in, we had boots on the ground. We had a group, a team that was out there distributing, and we created door hangers. So if you would just move forward a couple of slides, we'll show the door hangers. It included information on prevention, treatment, recovery services, and on the other side was overdose prevention. So we were able to get to people's homes while people were shut in, but provide this information in the hopes that people would see it and use it needed. And that, if you could go back 2 slides. So that was something that came out of this campaign and the data. The next is the importance of really, I spoke about the community outreach and neighborhoods, but the connections that were necessary. And with any community work, especially outreach in a community, there are many people who want to know, but there are those that really need to know. And thus the importance of relationships, especially between city administration, government departments, elected officials, city council. Some of our harshest critics, but also our important supporters. And the schools. During this time of COVID, we were able to train youth in Narcan as they came out of the pandemic and back into the schools. We now have Narcan in the schools and nalox boxes in our schools. And really during this time, as youth were kind of coming back into the mainstream, we were lifting up our youth voices. We created a kind of a coalition of youth that were speaking out and providing Narcan training to their peers. So at this time, the connections were important. It was important for all of our, leaders to understand the work, the community members to understand the work that was being done, not only during COVID, but as we came out, and why and how. And this was the education piece. Although it doesn't mean that the individuals will like or support our work, But what it does show is that we respected the position to give them the information, education, in the hopes that to keep our communication open, transparent, and know that there's a desire to always collaborate and partner. It's not always been easy here, but there was always hope of moving forward. We plan to relaunch the campaign in the spring of this year. So thank you for your time.
So next, we're going to pass it to Dr. Saracen from Landmark Medical Center. I just want to let my colleagues know we are running a little bit behind time. So just be aware of that as you move through your slides. Dr. Saracen.
I think that Susan telling me did not take too long. So my name is Matt Saracen. I'm the medical director of the emergency department at Landmark. Formerly worked at a Memorial Hospital in Pawtucket, Rhode Island. I'm also the medical director for 6 different EMS agencies throughout the state, many of which have high rates of substance abuse and opiate use in the communities. So this is something that I deal with on a daily basis. I see on a daily basis. And unfortunately, I do take care of a lot of patients who are post-overdose, suffer from opiate use disorder, and I have personally pronounced a large number of people within the state of Rhode Island who have succumbed to opiate use disorder. So this is something that is definitely near and dear to my heart. So before I quickly talk about the FOID project, I want to take you back about 10 years ago. And there was a law that was passed by the state legislature, signed into law by the governor at the time, which said each emergency department in the state had to follow a certain set of requirements, including discharge planning, offering peer recovery services, screening for opiate use disorder. And it was a very comprehensive plan that definitely has all best practices. But the problem was it didn't include any other funding. So you take an emergency department that's already stretched for resources. And if anybody's been to an emergency department lately or heard any of the public messaging from the Department of Health, it's emergency departments are overburdened. So now you take an overburdened emergency department and ask them to do more, and it became tough. So that you have these best practices. So the not so dirty secret is a lot of these emergency departments are not able to meet all of these requirements. So I took over as director of the emergency department at Landmark, and I said, well, that's not acceptable. Okay, to be able to say we're just not able to meet it really isn't an acceptable thing. We have to do better, especially since Woonsocket has some of the highest rates of opiate use disorder, but also some of the highest rates of opiate deaths. So in 2019, right before COVID, we started gathering some of our community partners and said, how can we talk to each other better? How can we get our patients from the emergency department to these community resources and be able to actually do the warm handoffs that are required by law? How can we do better? And that's when Susan Jacobson approached me, and Kathy was involved at the time, and said, hey, we have some money. Can we potentially bring in a CPRS team or peer recovery support team into the emergency department and Landmark and do better? And can we use that as it potentially to help you engage with the community partners? And we found that yes, it can. So the objective was to hire a CPRS team, be a point of contact, so that they can interact. And prior to that, Anchor had a contract to be able to provide peer recovery to all emergency department patients throughout the state, which was great, except as Susan mentioned, there's a very finite period of time in somebody who's post-overdose to be able to interact with them. And if somebody has just gotten Narcan, arrives to the emergency department, and they feel terrible because they're in active withdrawal, you don't have that much time. So we were having to call Anchor, and a lot of the patients were saying, I don't want to wait, because patients had the recovery coaches had to come from, a lot of them lived in the Providence area, or they said, hey, I'm headed down to Kent, or I'm headed down to Westerly, we'll come up there next. Well, 3 hours later, patients don't want to wait. So the embedding the peer recovery coaches solve 2 problems. The first is They didn't have to wait. We had the peer recovery coach in our emergency department. But the other thing is, it actually got rid of a consent problem. So with a outside peer recovery coach, we had to say, could we call someone in on your behalf? Because we employed the peer recovery coach and included that in the general consent for our emergency department, we were able to have that peer recovery coach walk in and say, hi, I'm the peer recovery coach. Can we have a talk? So we were able to cut down on time, and in the first month, we had more interactions with a peer recovery specialist than we had in the prior year with a peer recovery specialist. So that's a huge difference. So we're working, and then the other thing is our peer recovery coach and coach team have been able to work out these relationships with some of the other community partners and be able to say, hey, I have a person who just suffered an overdose. Can you see them tomorrow? Or hey, can you follow up with them? Or hey, we're giving them we want to start them on Suboxone. Can you follow up with this person tomorrow or later this week to continue those medications? So those are all successes that we've had. So our successes, we've been able to have people who can see people with empathy, decrease patient length of stay in the emergency department, because that's a big deal right now. We are short on beds. Every emergency department is short on beds. And we've also decreased repeat visits on some of these patients. We've built those relationships between our CPRSs and the community resources. And we've put these workflows on paper. We've been able to say, how can we make this work? Because as everybody knows, people can come and go within your organization, but to be able to have something on paper to say, this is our best practice and this is how it works, this is the person you need to call, we've been able to do that as well. So our biggest challenge is lack of resources, both financial and internal, financial and external. So the biggest thing is we have people who come to us for help, and they say, I'm finally ready to get help. Today's the day. I suffered an overdose. I suffered a near fatal overdose at home. One of my friends died. For whatever reason, today's the day I want to get help. And we can't give them help. They come and they say, I need help, and we search for beds, and there are just no beds available. So the lack of treatment beds and resources in the state has been our biggest challenge to the program, but also some of the other social determinants of health. So they come in and say, I'm ready to get help, or I need help, I need this assistance, but I'm homeless, I don't have a job, I don't have food. How do we address some of those other issues that go along with, it's hard to say, you should not do drugs, right? That's the, but when the person is suffering from joblessness, homelessness, and all of these other things, how do we get them those resources? Staffing issues. So it's been fantastic that all of these other organizations in the state are doing all this great work, but there's a finite pool of peer recovery coaches. So we've had trouble staffing and hiring peer recovery coaches because there's just not peer recovery coaches to go around throughout the state. And then the other challenge is starting Suboxone and ED. We thought we were going to be able to start Suboxone on a lot of patients right off the bat, but the reality is somebody has to come in withdrawal to be able to start them on Suboxone. So we've been talking about potentially starting things like home Suboxone initiation to be able to, for the people, especially the ones who have been on Suboxone in the past, to be able to get them Suboxone on Suboxone, or just using our resources that we've developed and getting them to the community resources that we've developed, the partners that we've developed. That's what I got. Thank you.
Thanks, Dr. Saracen. So we are really behind time now. And so if I can ask our colleague Melissa, and that was wonderful, Matt, please don't take that as any kind of criticism. But I'm going to introduce Melissa Babington from Sojourner House to talk about the work they've done around peer supports as well as housing. And if you can do that in about 2 minutes, that would be great.
I got you. Okay. Hi, everyone. I'm Melissa Babington. I'm the Senior Director of Emergency Operations for Sojourner House. Sojourner House requested funding to continue capacity to provide peer recovery overdose prevention services throughout all of our programs in the city of Woonsocket. We really try to focus on harm reduction in empowerment models all across our programs and services. Clients are trained in overdose prevention and safe use practices at all of our shelters and during our street outreach. The HES and the Backbone have really been a great support throughout this funding to be able to provide prevention for COVID, prevention for use, different things like that. And so each peer recovery specialist, we were able to hire 3 full-time peer recovery specialists on staff right now that work in each of our shelters and throughout our housing programs. And they provide overdose prevention, addiction, motivational interviewing, different things like that to all of our clients. So over the past year, we were able to provide services to Woonsocket and the rest of the state, but specifically for Woonsocket, we were able to pass out 68 naloxone kits. We completed 132 referrals for services in the Woonsocket community. We provided 76 hours of counseling. And we received approximately 250 hotline calls from the city of Woonsocket as well. All of our programs are geared for victims of domestic violence, sexual assault, and human trafficking. But we know with all of that comes a lot of other kind of issues, mental health, substance abuse, things like that. So we really try to focus on the harm reduction first. We provide 20 households with housing supports. We have a housing clinic right now in Woonsocket as well. And I think that's about it. So I'll wrap it up there. I just know that, there's not enough funding to provide resources and supports. And so it's been kind of just boots on the ground, kind of do what you can do type of work. So that's it. Thanks.
Thanks, Melissa. And actually, if we could go back a slide, I realized I jumped right over Community Care Alliance and Michelle Taylor.
All right. Good afternoon, everyone. Thank you. We've been really indebted to the HES and the Code 3 project. We started off with the Serenity Center, a peer-run recovery center that has expanded into a full array of services that includes our Safe Haven drop-in, an entire harm reduction team. And this is really built on the foundation of our peer recovery support staff. We have staff, obviously, with lived experience who have made their life's mission to work with this population, and they're looking at our people in the eye and saying, I see you, you're valued, and we care. And that makes all the difference in the world. So not only are we providing peer recovery support for individuals and groups, we have also been able to identify and open this drop-in center for people who are at any stage of recovery, including active use. So not only are we using a harm reduction approach, it is incredibly focused on person-centered and trauma-informed. Jess, who was highlighted as being part of the media campaign, started off as one of our peers and is now transitioning into the team leader of the Serenity Center. And she is working on becoming a licensed chemical dependency professional. So you can see the trajectory for a lot of our folks, and that means healing and recovery and a life of meaning. We do an enormous amount of wraparound supports. So we're not only focused on the harm reduction, but we're looking at all areas of support, connecting them with emergency shelter, housing, basic needs, treatment and recovery options as they are ready. And the lack of available housing remains our biggest barrier. And I know I'm coming up on my 2 minutes, so I'm going to stop there so we can move on. But I have to say this comprehensive approach and the support of the HES has really made it possible to create a lot of healing in the city of Woonsocket. So we thank you.
Thanks, Michelle. Last but not least, my colleague, Tammy Zerenner from Thunder Mist Health Center.
Hi, Tammy Zerenner, Program Director for Medication Assisted Treatment at Thunder Mist Health Center. Like Michelle said, we are so grateful for HES and the Code 3 funding that allowed Thunder Mist to employ a nurse care manager to support our Suboxone, at the time Suboxone waivered providers. So some of our objectives were to increase same-day access to MAT medications and harm reduction materials, strengthen relationships between community partners, to follow up care after a substance use disorder related ED visit, develop new workflows, harm reduction at Thundermiss, including staff training on harm reduction, naloxone distribution and fentanyl test strip distribution, and developing and implementing new protocols for Suboxone inductions in convenient care. Hiring the nurse care manager definitely allowed us to do a lot of these things. We, Thundermiss Health Center was able to train 1,319 staff over the last couple of years from 21 to 23. Workflows, a lot of these flows enabled patients to have same-day access. So pretty much over the last year, anyone that walked in Thundermiss Health Center, whether they're a patient or not, had same-day access to the medication-assisted treatment medications and harm reduction materials, handing out 1,359 naloxone kits. And this was not only to our community, but also to our staff. And the fentanyl test strips, 764 kits. We did receive some great referrals from Landmark Medical Center, not only current patients at Thundermiss Health Center, but also we were sent some new referrals for patients that did not have a PCP and also needed help with the SDOH insecurities. So I think probably the challenges have to do with we definitely need a lot more funding for the emergency room at Landmark. I would love to see them have peer recovery specialist in the ED 24 hours a day. Matt had made it very clear in the beginning that, you know, a lot of the fatal overdoses were happening in the middle of the night. And unfortunately, it's very hard to have a peer recovery specialist in the emergency room at night. But the peer recovery specialist that worked in the emergency room during the day did an amazing job. She had great communication. We developed workflows and fax cover sheets so that we could communicate. And I'm just so grateful for all of your support. Thank you.
Thanks, Tammy. We are way over time, so I'm not going to go through these lessons learned, but I will say that our partners throughout the presentation have noted many of them. And obviously launching this during COVID was very, very difficult. But I think the takeaway, we didn't really talk so much about municipal leadership and how important that has been throughout the process, but really building consensus with elected officials and administrators throughout the municipal government has been critical to really move forward a lot of these initiatives that require access to public space, policy changes, etc. And then I think that's our last slide. Thank you for your patience. We have a very, very enthusiastic group.
Susan, the whole code team, Lauren, thank you for this presentation. I want to acknowledge, we also had to reschedule the code presentation, which was originally scheduled for last calendar year. And we had to bump the group. And it's, as you can tell, a very coordinated, very comprehensive, very tightly working group. And so thank you for all of you for finding the time to present to us this afternoon and providing such comprehensive information about how you're approaching your work in Woonsocket. It's a wonderful example. Questions from the committee for any of our code presenters? Or comments? It was an excellent presentation. I don't think you could have left us with any room for questions or comments. Thank you all. Thank you, Susan. Thank you, team. Thank you, Lauren. Okay, we do have a little bit of administrative work ahead of us, and so believe it or not, we've been at this long enough that the first people are about to roll off, the first appointments of our community and subject matter experts are about to roll off. And our dynamic duo sitting next to each other, Dr. Brandon Marshall and Ernesto Figueroa, are the subject matter and community experts. I know you can reapply, and we invite you to reapply for our appointment on this committee, but it is also an open process, so it's not an automatic. As folks will recall, we are following the settlement agreement in terms of appointments to this committee. The community and subject matter experts have terms. We also want to acknowledge we have 2 vacancies to fill on the municipal side, and so we're working with the League of Cities and Towns for that. Both Kate and Bob's positions need to be filled, so we're slightly smaller, a little more intimate today than we would normally do. So that will happen, but it is time for us to open the call for nominations, not right this second, but this time of year, to open nominations for 1 community expert and 1 subject matter expert. The current terms for Brandon and Ernesto will conclude in March, so that the newly seated or returning people would begin with us at our April meeting. So, process steps, and this is a question for the committee. The first time that we filled these seats, you'll recall there were 5 seats to fill. We opened nominations, and in a second, I'm going to share with you some questions that we're proposing to use for the nomination process again. And myself and the state staff tried to, in part, to facilitate the process, and in part to respond to our very compressed timeline when the OSAC launched. We went through all the nominations and tried to identify candidates that we thought were a good mix of meeting the expertise and backgrounds and experience that were needed to serve on this committee. And so we proposed a quote unquote slate of individuals to this committee, and the committee voted on the appointments. The committee will again be asked to vote on the appointments. It's not a decision of mine, it's not a decision of the state staff, it's the committee's decision. But the question about process is one that I'm going to come back to in just a second. First, let me show you what the questions are.
Process first.
I'm going to jump around the side a little bit. Let me show you what the questions are that we're proposing asking. First, I want you to tell me, are we missing something? Should we be asking nominees, which could be self-nominated or nominated by someone else? Should we be asking them anything different? The basics, name, contact, if they are representing a community organization or a specific population that they want to call out, or an organization, and a bit more about their background. Then, because we want to maintain diversity in this committee, we're asking them if they feel that they identify with any of these groups and bring any additional dimensions of diversity to the OSAC. Including the other category, not assuming that we can reset all dimensions of diversity. And then brief essay, the goal is not to make this a arduous, college application process. For them to share a bit about themselves, their experience with respect to the overdose epidemic, how they would contribute, the expertise that they would bring, how they would contribute to the committee, significant challenges that the committee will face, and how they will contribute to our goals to achieve equity, and in particular, racial equity. And then just a short bio, and again, between the essay and the demographics, the bio, most of it's probably there, just a brief bio. Is there anything else that we should be asking nominees to share, or anything different? Yeah.
Yeah.
I think I know what you're gonna say. Let me make it so that you don't have to say it.
Okay, yeah.
Brandon and Ernesto, would you recuse yourselves from this discussion, since you might be considering renominating yourselves for this record. You don't have to leave the room for this recusal, but I'll ask you just to recuse yourself from the discussion.
That's great.
Sorry, did I
That's
get
great.
that?
I actually have to leave early anyway, so this is perfect. But before I go, just one question on if there are any under statute criteria for the 2 slots that we fill. Can you just remind us in the committee as to what are there any criteria for these slots?
And forgive me that I don't have this memorized of the exact language in front of me, but Brandon, you are a subject matter expert, which is what it sounds like. Special knowledge of the opioid epidemic, strategies to address the epidemic, subject matter expertise to bring to the table. And Ernesto is a community expert who brings lived experience and community networks and voice to the OSAC. That's in brief the requirement, yeah. Okay, are we missing anything from the nomination process? Yeah, Julie.
I'd be curious if anyone had applied the first time for one of these slots and whether and to what extent applicants have had interactions with the committee or the governor's overdose task force.
I so apologize, but I forgot to give you the mic. Do you mind repeating your recommendation?
Sure, I think it would be helpful to know, number one, whether the applicants had applied the first time and or whether they had attended any meetings or attended any meetings of the governor's overdose task force and in what capacity. Because obviously it's a community, and so I think just illuminating that for the committee would be useful.
Absolutely. Any other suggestions? Adi? Hold on.
So I think for the expert category, it might be helpful to try to that kind of like you did with what diversity would you bring to the OSAC, like what type of provider the person is, are they a frontline provider, physician, nurse, other type of treatment provider, researcher, that might be also helpful.
Just a couple minor points on logistics. I wonder if 250 words for all those questions, it's a little bit tight. So I would, page or two. Each. Oh, each. Oh, okay. Okay. Yes, I'm gonna agree with Dr. Burke. That does maybe seem like a lot, maybe cut down on a couple questions.
Which would you recommend cutting?
Couldn't you make this just
One long essay with
one
more
long
words?
essay question that
Okay.
addresses all of these, but give more words? Would that be easier?
Sure.
Yeah, I think that would actually make sense. And then people may have different strengths within those, and then they could sort of focus on one or the other. Maybe a 2-page limit or something like that. And then at least for the expert advisory person, it'd be nice to see the full CV, instead of a short biography. I think at least in academia, it's nice to see like all of it to kind of get a sense of where they trained and et cetera, et cetera, et cetera.
Yes, process questions or is that in a second?
We're gonna get to process in just a sec, yeah. You can lead off with that. Yeah, right. Oh. Get used to this mic, sorry.
I think that it's important for the experts to, yes, have their role in the community in the CV, but I think we also would want to know about the community involvement of the person bringing the community voice. That's equally as important if we're asking them to be a representative. So it seems like that might be easiest to address in like the attached short biography, like what roles have you held that are representative of it, or however we want to phrase it there, but maybe just ask for some particular points in the biography. But I think the qualifications we want to hold out for the expert representative are also important for the community reps.
You get all the items? Thank you. Okay. So, actually, Justin, process, let me just lead a huge play to you. We don't meet in February, our next meeting as no second in March. At our March meeting, we'll be considering the nominations and voting to fill those 2 slots. Those persons, and there is a slide for this, would start their term. Thank you. Those persons would start their term in April. May, excuse me. Let me just pause. Let me give a shout out to Gianna because it was a sophisticated game of Tetris to figure out our meeting calendar for this year. And I can't even keep it straight in my head. And she really had, between figuring out times that just worked on my calendar and the state staff calendar, and then where the room is available, and then bringing in her own equipment to facilitate the tech today. She's just been a superstar. Heavily in the other duties as assigned line of the job description for the last couple months. So I just want to acknowledge and thank you. We will vote in March for this person to start at the next meeting, which is in May, not April, because you have April. How do we select is the question for this committee. Options include, you could ask the state staff and myself to review the nominations and present a recommended slate. Of course, you can change the slate, but you could ask us to kind of do that pre-work and recommend something for you all to react to and make adjustments. That's one option. Second option, we can start with no slate. Whiteboard on March 26th and make the selections together. We could ask folks who are nominating themselves or have been nominated, have accepted the nomination, to be prepared to make a brief presentation if you want to hear from them anyway, but be prepared to answer questions. So there's, permutations of this. How would the committee like to proceed? What feels both thorough and appropriate to advance our work? To get a representative of that.
And how many nominees do we have in the past?
Well, we had about 25-ish when we started the OSAC. Don't know what to expect this time around, but about 25-ish.
Are we allowed to do more than 2?
No, not at this time. Yeah. I didn't give you the chance to ask a question.
Yeah, so my question is, can we do more than the 2? And how flexible might that be in the idea, especially for the community committee member, being proactive in trying to expand the community voice? This seems like a very easy way to do that. And especially if there are outstanding applicants, maybe not requiring doing more than one, but I think if there were a lot, that might be a really great thing to do, and how flexible that would be.
Unfortunately, we are not gifted with that flexibility. But I would otherwise agree.
If I could make a recommendation, if it's only 25, maybe have the staff come up with a recommended slate, but then list a summary of the 25, and then give the committee the opportunity to modify things. I serve on a different board, and they do that each year. The board has a slate, but then any member can modify it.
We can certainly do that. The committee will get all of the nominations. You will see all of the applicants. Regardless. Yes.
Sorry, can I choose authority it is to keep it at one community member?
The settlement language, so we're bound by that. Yeah.
That's
I welcome the pushback, and just for the record, it is ridiculous and stupid that we can't just post purchasing information on the. I've heard this frustrating, and I continue, it's as late as 11 something today, to push back with the OH, why? I didn't actually say that, but that was implied. That's why it works.
So I'm not the open government meetings expert, and I think that your suggestion is a good one. I just worry about what can be done outside of the public meeting and what can't be done to avoid things like long form and all these all these things. So, but on the other hand, this may be more of like a personnel type of, I don't know, decision. So I'm not sure if, maybe you guys have already thought about that and through that, because it would be, I think, maybe if everything was circulated to the committee and the committee members could then circulate back independently and individually, their maybe top 2 or top 3 for each category, like for the expert category and community category. And then the EOHS sort of looks at that. And if there is some consensus about or whoever emerges is the clear top 3 or whatever per category, have that be the slate, or top 5, whatever it is.
Can I make a friendly modification, just to keep within the bounds of what I think our authorities are? Oh, you'll correct me. I think as chair, I could exercise the authority to recommend a slate. Correct me if I'm wrong, Marty. Which administratively I would think the EOHS staff are helping facilitate that process. I like the suggestion of opening up the committee and having individual contact back, because it couldn't be a group email, because that would violate open meetings law. But I could receive questions or comments or suggestions from the committee members and compile that information and present something to the committee. Purely for the sake of kind of advancing the conversation, facilitating the conversation, decision-making process. But Marty, it looks like.
No, yeah. I did recently get to sit through a presentation from one of your colleagues who is the expert on budget meetings.
She was here.
And it's just that y'all can't talk about this amongst yourselves. That's the thing. You can't discuss and like come up with an idea for a slate because that violates open meetings. But you can individually talk with the chair who is non-voting and talk about that. And I think Kathy said something that is a thought that I just want to put out there. There's nothing that says that the expert can also be a strong community member. So.
Can I don't mind actually. So I'm gonna say, I'm Kathy Schultz, I'm a person in long-term recovery, and I'm an expert in recovery. I'm also an expert, like, Dennis is one of our committee members, he's an expert in harm reduction as well as recovery. So, like, although we, I happen to have a degree and have some numbers behind, letter numbers. I wish I had numbers behind my name, letters behind my name. But like, first and foremost, most of my career and like where I have moved up the ladder or whatever it may be, was really because I'm a subject matter expert. So I don't want to push y'all to make a decision. And I'm not saying that our PhDs and our doctors are not super important, because you all are. Like, I learn from you all the time. But what I'm saying is that it's your discretion to think of that as an expertise. Because it is, because if you sat in my shoes 20 years ago, you'd understand what I'm saying. So anyway, thank you, Marty.
Any other suggestions on process from the committee? Is anyone opposed to the process that he recommended, where we send out the full slate to the committee? You all can send me your thoughts, questions, suggestions individually. I can compile that to just facilitate the conversation when we come together in March. Excellent, we will do that. And we will take your feedback on revising the nomination questions process.
The only comment would be if there's like less than 10, or if there's a small number, it may be helpful to send them all out. If there's like 30 or 40.
We're gonna send them all out no matter what.
Okay.
You're gonna get a big email.
I was gonna say the opposite. If there's like 100, maybe an initial vetting would be efficient.
I would love to go to 100. That's a challenge to the Rhode Island community. Even still, I would be most comfortable sending everything out. Okay, thank you. Excellent. Okay, any other to the staff that I'm missing anything before we go to public comment? Didn't you quit? Okay, we're gonna go into public comment. I'm gonna ask for anyone on the Zoom to unmute anyone in the room, to take a mic, and to introduce yourself and limit yourself to 2 minutes if you'd like to make public comment. It's coming, Sarah.
Stand up and I think he needs a.
Hi, this is a question about what we were just talking about nominees to the committee. Because I'm starting to think of possible nominees that I would like to put forward who are content experts in prevention. And just wondering how, if a person is either works for an organization that either is a current recipient of opioid settlement funds or could be, how is that handled? Does that exclude them? If it doesn't exclude them, how is that handled on the committee?
Yeah, great question. It does not exclude them. It does require, though, that they be diligent and we as a committee and I as a chair be diligent in making sure that that person recuses himself or herself or themselves. If we are consider, because we're not recommending particular agencies to be funded, so this shouldn't be a huge problem, but if we're approaching the line of recommending something that, for instance, only one agency can do, and that agency is represented by someone on the committee, that that person recuse themselves from the discussion.
Okay, that's helpful to know.
Yeah. And Sarah, congratulations on your announced retirement. Thank you. On to the next great thing. Sorry.
Courtney Harness from Heron Project. I just want to make note of the committee's concern regarding access to ocean state procures and make sure that we know when we're looking at documents that are focused on equity, that when we're talking about who has knowledge and access to procurement and RFPs, that if you do not have access or you do not have knowledge of those RFPs, that process is in and of itself inherently inequitable. So I would urge this committee at the next meeting to vote on a process in which any and all procurements that include anything having to do with prevention and recovery are made public.
Thank you. I will say all procurements are public. They could just be public in their ease of access to read them and respond. Are you seeing anything on the chat? I can't see the chat. I'm afraid to.
But I do think that this has come up a few times in different meetings, and I think the Settlement Advisory Committee has identified ways where the efficient governance component could be improved, and I think it's still good to just continue to keep note of that where there are inefficiencies in getting money out, execution in an effective way, and making sure. So I appreciate the comment.
And we, at the outset of the OSAT, made very clear and repeatedly discussed, and one of the champions for that is in the room, that we don't want the same old entity, not that we're opposed to the same entities being funded, but we want to make sure that every entity has access to be funded. And if you know how to navigate the procurement side and process, that gives an advantage. And it's not the most transparent process otherwise, and it definitely takes you practice and comfort, familiarity to get comfortable with. So we continue to work on it. And Adi makes the point, which if I can relay your comment, Adi, which is why we're trying to synchronize the selection of a subject matter and community expert along with the backfilling of the municipal seats, is that that's another dual hat. We may have municipal leaders who have particular experience and expertise that would help to either fill a gap or amplify a level of experience on this OSAC that we really want to tap into. So the two are not mutually exclusive, absolutely. Okay, if no other public comments, I would accept the nomination to conclude our meeting today. With a note for the record that it is 4 minutes early. Good job, Sarah. Thank you, Joe. Second, enjoy your afternoon, everyone. Thanks, guys.
How are you?
Like that now.
Good.
Yeah.
Yeah.